Hi guys, this is Dr. Carmel Apau and today I will be discussing about liver function tests. The liver is the largest and most complex organ of the GI tract, and it is composed of three systems, namely the hepatocyte, which is concerned with the metabolic reactions. Second is the biliary system, which is involved with the metabolism of bilirubin and bile salts. And lastly, the reticuloendothelial system, which is concerned with the immune system and the production of heme and globin metabolites. The function of each of these systems can be measured conveniently and virtually non-invasively by determining the serum levels of specific analytes in the so-called liver function test profile. The uses of the liver function test profile are the following. And is generally divided into two categories, namely the test based on metabolic functions and the test based on synthetic functions. Let's first start with the metabolic function, beginning with bilirubin. So bilirubin is a breakdown product of the porphyrin ring of heme-containing proteins. It has two fractions, namely the unconjugated and the conjugated bilirubin. The unconjugated bilirubin is also called the indirect bilirubin. It is insoluble in water and is bound to albumin in the blood, while the conjugated or the direct bilirubin is water soluble and it is excreted by the kidneys. Now let us review the bilirubin metabolism to understand further the disorders associated with the increase and the decrease of this analyte. So the bilirubin is produced from metabolism of heme primarily in the spleen, and it is transported to the liver bound to albumin and enters the hepatocyte or the liver cell by binding to a transporter protein. So here it binds to the transporter protein. Then it crosses the cell membrane, thus entering the hepatocyte. Then it binds to Y and Z proteins, which is not shown in the picture, and then to ligandin for transport to the smooth endoplasmic reticulum. So in the smooth endoplasmic reticulum, the bilirubin is conjugated to glucuronic acid by the enzyme UDP glucuronyl transferase 1, producing the bilirubin monoglucuronides or the bilirubin diglucuronides. And then the conjugated bilirubin is then secreted into the canaliculi by a secretory protein, so the blue crescents, called the adenosine triphosphate binding cassette transporter protein. Unconjugated bilirubin is elevated in hemolysis. This is due to the increased levels of hemoglobin released from the red blood cells. And it is the bilirubin formation is greater than the liver clearance. That's why there is elevated bilirubin levels. It is also elevated in the Gilbert syndrome or Crigler-Najjar syndrome, which are caused by gene mutations and deletions in the proteins encoding the UDP glucuronyl transferase. So that's why the bilirubin, the unconjugated bilirubin cannot be conjugated. So that's why there is a buildup of your unconjugated bilirubin. In Gilbert syndrome, there is only a mild increase in unconjugated bilirubin, while in Crigler-Najjar syndrome, there is marked increase associated with kernicterus and severe motor dysfunction and retardation. So going back to the picture, so the problem with the Crigler-Najjar and the Gilbert syndrome is there is a mutation in the UDP glucuronyl transferase. That's why the unconjugated bilirubin cannot be conjugated. So that's why there's a buildup of the former. Conjugated bilirubin is elevated in excretion deficits like the Dubin-Johnson syndrome. So there is a blockade of the excretion of the conjugated bilirubin into the canaliculi due to the defects in the secretory protein ATP binding cassette transporter protein. So this is also associated with mild jaundice and intense dark pigmentation of the liver due to the presence of lipofuscin pigments. So again, going back to the picture, so the problem in Dubin-Johnson syndrome is the mutations in the secretory protein ATP binding cassette transporter protein. So the conjugated bilirubin cannot be excreted. So also conjugated bilirubin is elevated in biliary obstruction, in which the most common cause in adults is cholelithiasis or gallbladder stones. So 90% of cholelithiasis is accompanied by an increase in alkaline phosphatase. Also, conjugated bilirubin is increased in inflammatory conditions such as ascending cholangitis. Also, there is a concomitant increase in ALP in cholangitis. Conjugated bilirubin is also increased in hepatitis. So there is destruction of hepatocytes that causes blocking of the bilirubin conjugation and excretion. That's why there is an increase in both direct and indirect bilirubin. So the reference values of bilirubin is age and gender dependent. So it reaches peak levels at ages 14 to 18, falling to stable levels at age 25. And it is more increased in males than in females, and also it can be increased in strenuous exercises. Next analyte is ammonia, which is produced in the body during normal protein metabolism and by the intestinal bacteria, primarily those in the colon. So ammonia is metabolized exclusively in the liver. So the liver contains the enzymes for the Krebs or the urea cycle, in which the ammonia is converted to a non-toxic substance, that is urea, and this is readily excreted. So in severe liver injury, the urea cycle enzymes are no longer present. So that's why there is a buildup of ammonia and arginine, which has neurotoxic effects, leading to hepatic encephalopathy. Serum enzymes are released from hepatocytes as a result of injury to the cell membrane that directly causes extrusion of the cytosolic contents. So the major diagnostic hepatocellular enzymes are located at various sites in the hepatocytes, giving rise to different patterns of enzyme release with different causes of injury. Okay. So ALT and AST are primarily found in the cytosol or the cytoplasm. So with membrane injury, as in viral or chemically induced hepatitis, these enzymes are released and enter into the sinusoids, raising the blood levels or the plasma levels of AST and ALT. The mitochondrial aspartate aminotransferase is released primarily with mitochondrial injury as caused by ethanol, like in alcoholic hepatitis. While your alkaline phosphatase and your gamma glutamyl transferase are found primarily on the canalicular surface, so the excretory function. So the bile acids accumulate in cholestasis and dissolve membrane fragments, releasing bound enzymes into the plasma. So to summarize, the enzymes that reflect damage to the hepatocytes are your aminotransferases, your AST and ALT, while the enzymes that reflect cholestasis are the following. So your alkaline phosphatase, gamma glutamyl transferase, and your 5-nucleotidase. So we will discuss each of these enzymes one by one. starting with the aminotransferases or the transaminases. So again, this includes the AST or your serum glutamate oxaloacetate transaminase or SGOT, and your ALT or your serum glutamate pyruvate transaminase or your SGPT. So these two enzymes require pyridoxal phosphate, like vitamin B6 as a cofactor, and they are sensitive indicators of liver cellular injury and are most helpful in recognizing acute hepatocellular diseases such as hepatitis. So AST is found in the liver, cardiac muscle, skeletal muscle, kidneys, brain, pancreas, lungs, leukocytes, and erythrocytes in decreasing order of concentration. So it is non-specific in the liver, while your ALT is found primarily in the liver and is therefore a more specific indicator of liver injury. So just remember ALT has letter L, so it's found primarily in the liver. So, in acute hepatocellular injury like hepatitis, the AST will be higher than that of the ALT initially because of the higher activity of AST in hepatocytes. But within 24 to 48 hours, particularly if there is ongoing damage, the ALT will become higher than AST based on its longer half-life of 47 hours. In chronic hepatocyte injury or cirrhosis, ALT is more commonly elevated. But however, if fibrosis progresses, the ALT activities typically decrease or they typically decline. In end-stage cirrhosis, both enzymes are generally not elevated and may be low as a result of massive tissue destruction. And in acute fulminant hepatic failure, both aminotransferases are markedly increased. Lactate dehydrogenase is a cytosolic glycolytic enzyme that catalyzes the reversible oxidation of lactate to pyruvate. So it is composed of two chains, H and M, so H meaning heart and M meaning muscle, 4 subunits and 5 forms from LD1 to LD5. So lactate dehydrogenase 1 and 2 predominates in the cardiac muscle, the kidneys, and erythrocytes, while lactate dehydrogenase 4 and 5 are the major isoenzymes found in the liver and in the skeletal muscle. So lactate dehydrogenase becomes elevated in hepatitis. So there is these increases are transient and return to normal by the time of clinical presentation. The large increase in lactate dehydrogenase to levels of more than 500 IU per liter, combined with an increase in ALP to levels more than 250, and in the absence of other dramatic abnormalities in the liver function enzyme levels, these could mean that there is a space-occupying lesion in the liver, such as metastatic carcinoma and primary hepatocellular carcinoma, or rarely benign lesions such as hemangiomata or hemangiomas and adenomas. So the rise in alkaline phosphatase is due to the blockage of the local canaliculi and ductules by the masses or any tumors in the liver. Alkaline phosphatase is present in the liver, the bone, the kidney, intestine, and placenta. And it is found on the canalicular surface and is therefore a marker for biliary dysfunction together with your gamma glutamyl transferase. So in obstruction of the biliary tract, the ALP rises rapidly to values exceeding 10 times the upper limit of the normal, again due to the increased synthesis and decreased excretion of the enzyme. It is also moderately elevated in most instances of jaundice resulting from hepatic injury, and when the resulting cholestasis is relieved, the serum ALP levels fall to normal more slowly compared to bilirubin. Gamma glutamyl transferase is also found in the canalicular surface of the hepatocyte. So this regulates the transport of amino acids across the cell membranes, and they discriminate the source of elevated alkaline phosphatase. So if the ALP is elevated and the gamma glutamyl transferase is correspondingly elevated as well, then the source of the elevated ALP, since the ALP has many sources, so if it is elevated together with increased GGT, then the most likely source of elevated ALP is the biliary tract. So it is elevated in chronic cholestasis due to primary biliary cirrhosis or sclerosing cholangitis. Those who chronically abuse alcohol, so to those who drink alcohol chronically, might as well have your GGTs tested. And also it is elevated in obstructive disorders and with space occupying lesions in the liver. Your 5-nucleotidase like GGT is most commonly used to determine whether the source of an elevated ALP is liver or bone. So if ALP is increased together with 5-nucleotidase, then the source is specifically the liver. But again, this test is not widely used. Alpha fetoprotein or AFP is synthesized by embryonic hepatocytes and fetal yolk sac cells. So it peaks in the second trimester of pregnancy, reaching levels that constitute up to 1/3 of the fetal serum protein. It has an unknown function, but it may be immunosuppressive, preventing fetal destruction by the circulating maternal antibodies. So alpha fetoprotein is elevated in the following diseases: in fetal neural tube deficits or defects, after acute hepatic injury from regenerating hepatocytes, hepatocellular carcinoma, and germ cell tumors such as yolk sac tumors of infants and your Sertoli Leydig cell tumors. Now let's proceed to the synthetic function of the liver. So the liver is the site of synthesis for most plasma proteins except your immunoglobulins and the von Willebrand factor, which is synthesized in the endothelial cells and in megakaryocytes. So extensive destruction of the liver tissue will result in low serum levels of the proteins, specifically also the albumin levels. So the albumin is the major protein produced by the liver, and low serum albumin levels due to liver disease are almost always caused by massive destruction of the liver tissue. In cirrhosis, elevated hydrostatic pressure in the portal system and low colloid osmotic pressure results in ascites. So serum globulins are a group of proteins made up of gamma globulins. So they are called immunoglobulins, which are produced by the B lymphocytes, and alpha and beta globulins produced primarily in hepatocytes. The gamma globulins are increased in chronic liver disease such as hepatitis and cirrhosis. And if there is a diffuse polyclonal increase in IgG levels, these are more common in autoimmune hepatitis, and increases in the IgM levels are common in primary biliary cirrhosis, and increases in the IgA levels occur in alcoholic liver disease. So the coagulation factors, with the exception of factor 8, so which is produced by the vascular endothelial cells, they are made exclusively in the liver. So because of their rapid turnover, the measurement of the clotting factors is the single best acute measure of hepatic synthetic function. The serum prothrombin time measures the efficacy of the extrinsic clotting system, which is made up of the factors 2, 5, 7, and 10. So the INR, or the International Normalized Ratio, is used to express the degree of anticoagulation to those patients who are on warfarin therapy. So serum prothrombin time is elevated in hepatitis, in cirrhosis, and disorders that leads to vitamin K deficiency, such as obstructive jaundice or fat malabsorption. Autoimmune disorders could also be diagnosed with the help of the following autoimmune markers: the anti-mitochondrial antibody, which is a marker for primary biliary cirrhosis, and the anti-neutrophil cytoplasmic antibodies, or your ANCAS, which is a marker for primary sclerosing cholangitis. So, having all those discussed, now let's proceed to the diagnosis of liver diseases. So, in hepatitis and acute injuries or necrotic lesions, it causes primarily a marked rise of your cytosolic enzymes AST and ALT. So the cellular injury and the necrosis also causes a rise in other enzymes such as lactate dehydrogenase. And if there is biliary injury, the ALP also rises with gamma glutamyl transferase and your 5-nucleotidase. So again, in hepatitis and other acute liver injury, increased AST, ALT, and lactate dehydrogenase. Hepatocyte injury causes loss of the conjugation of the transported bilirubin. Thus, indirect or unconjugated bilirubin also rises. And in hepatitis, less than 80% of the liver is destroyed, so total regeneration will occur, and enough tissue is still present to enable adequate levels of protein synthesis and ammonia fixation as urea. Thus, the total protein and albumin and ammonia levels remain normal. In cirrhosis, it is characterized by two cardinal features, specifically the fibrosis, preventing the regeneration of liver tissue wherever the fibrosis has occurred, nodules of regenerating liver tissue, which are the only source of any kind of hepatocytic function, and also one is the loss of the normal architecture of the liver. So cirrhosis has a reverse pattern of hepatitis. So again, in hepatitis, there is increased ALP, there is increased AST, ALT, and lactate dehydrogenase. So in cirrhosis, since more than 80% of the liver tissue is destroyed, and there is no regeneration of damaged liver tissue due to fibrosis, the AST and ALT and lactate dehydrogenase levels tends to be normal or low, or occasionally just mildly elevated. And the total protein and albumin are both abnormally low, and the serum ammonia levels are elevated because, again, the enzymes in the urea or Krebs cycle is not present anymore, and that's why ammonia cannot be converted to the non-toxic form urea. Okay, and also the indirect and direct bilirubin tends to be elevated due to insufficient viable liver tissue and fibrosis destroying the cholangioles. So in cirrhosis, again, AST, ALT, lactate dehydrogenase could be normal, low, or occasionally mildly elevated. Protein and albumin are abnormally low, and you have elevated or increased levels of ammonia and indirect and direct bilirubin. Acute biliary obstruction, which is mostly caused by stones in the biliary tree or by neoplasms that block the bile excretion, causes elevations in direct bilirubin and biliary tract alkaline phosphatase, along again with the enzymes GGT and 5-nucleotidase. But all the other liver function tests are normal. So in acute biliary obstruction, since the canalicular area is affected, that's why the canalicular enzymes are more or less increased. So increase in ALP, GGT, and 5-nucleotidase. Space-occupying lesions, which I discussed a while ago, has elevated ALP and lactate dehydrogenase, and the most common cause is metastatic carcinoma to the liver. Passive congestion has mild elevation of AST, ALT, and lactate dehydrogenase. So these are the cytosolic enzymes. And in more severe cases, elevations of total bilirubin and alkaline phosphatase. In acute fulminant hepatic failure caused by Ray's syndrome and hepatitis C, there is total liver failure. And the picture of the liver function test is a combination of hepatitis and cirrhosis. So AST and ALT are elevated, but the total protein and albumin are markedly decreased. Ammonia levels are very elevated, leading to hepatic encephalopathy. And also, there is elevation of lactate dehydrogenase, alkaline phosphatase, and bilirubin. So this table summarizes the um, all the conditions that I have discussed and the patterns of the liver function test. So again, in hepatitis, what is increased are mostly your cytosolic enzymes, namely your AST, ALT, and lactate dehydrogenase. In cirrhosis, it is the opposite of hepatitis. So there is decreased total protein and albumin, while your AST, ALT, lactate dehydrogenase could be normal, while your bilirubin and ammonia are increased. In biliary obstruction, the canalicular enzymes are the ones elevated, namely your alkaline phosphatase together with gamma glutamyl transferase and your 5-nucleotidase. And also, bilirubin could also be elevated due to obstruction. In space-occupying lesions, what is increased is your lactate dehydrogenase together with your alkaline phosphatase. While in passive congestion, there is slightly increased cytosolic enzymes AST, ALT, lactate dehydrogenase, and alkaline phosphatase as well as bilirubin, while total protein, albumin, and ammonia are in normal levels. While last, in your acute fulminant liver failure, AST, ALT, lactate dehydrogenase, alkaline phosphatase, bilirubin, and ammonia are increased, while your total protein and albumin is decreased. So this disorder is a combination again of the pattern of hepatitis and cirrhosis. So that's it. I hope you learned something of the liver function test, and I hope you will apply it in your future use, especially during internship or in residency. So thank you so much for listening, and I'll see you when I see you.